Okay, for this series of slides, we will be discussing on acute pancreatitis. So, acute pancreatitis is an inflammatory disorder of the pancreas that is characterized by edema and, when severe, necrosis. So, it ranges from a mild self-limiting inflammation of the pancreas to severe and critical disease. So, smoking is an independent risk factor for acute pancreatitis. Etiology for acute pancreatitis: most common cause for this disease in 80% of cases would be gallstone and alcohol. So median age at index of presentation. For alcohol and drug-induced pancreatitis, that would be the third or fourth decade of life. For the gallstone and trauma, it's around the sixth decade. For gender distribution, it's more common in males for the alcoholic etiology and females gallstones. So sustained alcohol ingestion is associated with current acute pancreatitis, typically ingestion of 100 to 150 grams per day. Chronic pancreatitis may develop in susceptible individuals who have been drinking for more than a decade. Iatrogenic causes can occur due to trauma to the duct or parenchyma after surgical procedures, such as biopsies, bile duct exploration, distal gastrectomy, and splenectomy. This may also occur due to splanchnic hypoperfusion with cardiopulmonary bypass, cardiac transplant, hemorrhagic shock, and major trauma. So the most common cause iatrogenically is ERCP, found in 5 to 10% of cases. So hereditary pancreatitis is an autosomal dominant disorder usually related to mutations of the cationic trypsinogen gene, or PRSS1, causing premature activation of trypsinogen to trypsin, thus causing abnormalities of ductal secretions, and this promotes acute pancreatitis. So tumors: approximately 1 to 2% of patients with acute pancreatitis have pancreatic tumors. An episode of acute pancreatitis can be the first clinical indicator that the tumor is present. A pancreatic or periampullary tumor should be considered in patients with idiopathic acute pancreatitis, especially in patients who are over 50 years old. Hyperlipidemia can also come in play when it comes to acute pancreatitis. Type 1 and 5 hyperlipoproteinemia can occur in association with marked hypertriglyceridemia. So this causes increase in lipase, which liberates toxic fatty acids into the pancreatic microcirculation. So there is microcirculatory impairment and ischemia after this cascade. Dietary modifications and drug treatments are employed to lower triglycerides. Drugs may cause acute pancreatitis as well, such as thiazide diuretics, furosemide, estrogen replacement therapy in children who undergone steroid therapy. Certain chemotherapeutic agents can also cause acute pancreatitis, as well as anti-immune drugs and other lipid-based drugs such as propofol. How do we manage acute pancreatitis? It is a coordinated, carefully supervised, multidisciplinary management. So all suspected acute pancreatic patients should be admitted to the hospital. In mild acute cases, it's usually less than a week of hospital stay. But for severe and critical acute pancreatitis, it's weeks or months of intensive treatment. For mortality risk, the risk is less than 1% for those with mild diseases, um, increasing to around 10% for those with moderate disease, and severe cases around 20 to 40%, while it's more than 50% in critical cases. So for the diagnosis of acute pancreatitis, the symptoms usually are acute onset of a severe constant epigastric pain that often radiates through to the mid-back. So elevation of serum amylase or lipase is usually seen, values more than 3 times upper limit of normal. Imaging, which is contrast-enhanced CT scan, is only required for the diagnosis when these diagnostic criteria are not met. So serum amylase concentration increases almost immediately with the onset of disease and peaks within several hours and may remain elevated for 3 to 5 days. There's no correlation between the extent of serum amylase elevation and severity of pancreatitis. In fact, a milder form of acute pancreatitis is often associated with higher levels of serum amylase, compared with that in a more severe form of the disease. So abdominal tenderness, often with signs of peritonitis in the upper abdomen, is one of the clinical signs of acute pancreatitis. There are several physical examination findings, such as the Collins sign and the Gray-Turner sign. Collins sign is umbilical bruising, while Gray-Turner sign is flank bruising. So these are caused by pancreatic fluid and bleeding from the pancreas into the retroperitoneum. Tetany as a result of hypocalcemia may also happen, and azotemia with elevated blood urea, nitrogen, and creatinine levels may also be seen. Other findings might also be hyperglycemia and hypoalbuminemia. So what about pain management? Pain is the cardinal symptom of acute pancreatitis. Analgesia should be administered IV first, at least at the onset and before oral intake has been established. So mild pain can be treated with nonsteroidal and anti-inflammatory drugs, and severe pain would require opioid analgesia. Morphine is to be avoided because it causes sphincter of Oddi spasms. So there are many ways of predicting severity of acute pancreatitis, one of which is the Ranson's prognostic signs of pancreatitis. There are two different criteria. One is for acute pancreatitis not due to gallstones, and the other is criteria for acute gallstone pancreatitis. So for us to use this, fewer than three positive criteria would predict a milder form of acute pancreatitis, uncomplicated disease. But if it's more than six positive criteria, it predicts a severe disease with a mortality rate of 50%. So determining etiology. So the history of alcohol ingestion must be ascertained and preferably confirmed with blood ethanol levels. Gallstones is confirmed or through ultrasonography, and a gallstone etiology is more likely in females over the age of 50 with an elevation of alkaline phosphatase of more than 300 IUs per liter or alanine transferase of more than 100 IUs per liter and amylase levels of more than 4,000. So in the absence of gallstone and alcohol, a systemic approach to identification of another factor is done through history of drugs, trauma, ERCP infection, and measuring serum triglyceride and calcium. The most important intervention in early management for acute pancreatitis is fluid therapy. It is to restore and maintain circulating blood volumes. Best to resuscitate with a balanced crystalloid and aim to restore normal blood volume, blood pressure, and urine output. In the elderly and patients with cardiac and renal disease, we have to be careful since there is a higher risk of over-resuscitation in these population. In patients who are severely ill or in those presenting with undifferentiated abdominal pain, it may be necessary to perform a CT scan to diagnose acute pancreatitis. The primary purpose of cross-sectional imaging is the diagnosis of local complications, particularly the development and extent of pancreatic necrosis. Magnetic resonance imaging, or MRI, is superior to CT scanning in detecting any solid content within the collections. Arterial phase CT scan is helpful in determining if there's pseudoaneurysm, active bleeding, or hematoma. In the management of acute pancreatitis, cholecystectomy is essential to prevent recurrent gallstone-associated pancreatitis. If the surgery is done in the same period of admission, it's called an index cholecystectomy. It appears safe and can almost always be accomplished through laparoscopic means. It is not suitable for patients who have had local pancreatic complications, which includes a large inflammatory mass that extends into the porta hepatis. In these cases, an interval cholecystectomy is done, which is performed after resolution of the inflammatory process. If surgery is required for the management of a local complication, then a cholecystectomy is often performed at that time. That's the end of this presentation. Thank you for listening.